I was going.
Now, these guys actually practice medicine.
I was going.
So I think we better get into
and I'm going to
their
ask,
own viewpoints.
Is Dr. Cutler, you're up there in Boston at the Harvard system, and the Department of Justice recently is quietly looking into the pricing powers that partners have. Essentially, I think they're trying to say that they might be gaming the system or something. Is that a problem that causes, related to the Dartmouth Atlas, where there's certain areas that supposedly spend more than other areas? Is this an issue that you'll see possibly being addressed at a national level by the HHS or the Department of Justice to try to limit the power of these organizations?
It's complicated. Of course, the thing that triggered the federal action here is a report put out by the Attorney General where she showed how much different providers are getting from different insurance plans. And at the top of the list were the partners hospitals. And at the bottom of the list were the hospitals that serve more of the poor people in Massachusetts. And so that's triggered a lot. I don't think, although we don't have very good data, my guess is that's not that different from the typical American city, where if you look at the biggest cities in the country now, the biggest hospital system has a quarter of the patients and close to 40% of all the profits. In Boston, it's 50% of the profits. In most areas, it's about 40% of the profits. And so what that's reflecting is that the bigger folks are getting higher prices, and they've done it by consolidating, by bringing together a lot of volume. Whether the federal government has had a very poor antitrust record in going after hospital mergers. In the Clinton years, the Justice Department prided itself on the fact that it won every antitrust case it brought, with the exception of healthcare, where it lost every antitrust case it brought. And that's because it's very difficult to win when you've got these local hospitals saying, look, we're taking care of the poor, we're providing research, we're providing all these community goods. I think the way to get at this is going to be not to go through the kind of price regulation or what the government does on the fees route, although we're thinking about that up here. I think really the way that we're going to get through this is the kind of transparency performance route, where we're going to measure how well these organizations are doing, and we're going to give that information to people and insurers and let them act on it. So, for example, partners may or may not be better at some conditions. It's certainly more expensive at a lot of them. So we should give that information and those incentives to people and say, you can go there if you want, but you should understand you're paying 40% more, and as best we can tell, the quality is no higher for this thing you're getting, or the quality is higher for this particular thing. But it's been and it's something Donna Schiller was mentioning, the lack of information has made it very difficult to deal with this. And the more information we have, the better position we'll be in to say, are you really getting value for your money? And if not, maybe you should think about something else.
Let me make a comment here to add to what was said. The most critical determinant in the amount of margin that a hospital can make, let's assume that this is a well-managed hospital, has to do with the payer mix. Typically, if you take a hospital that has a vast majority, if not, say, 75% of the patients who would be insured by private payers rather than government-funded patients, or even more challenging people with no insurance, you will find that these hospitals typically will be able to create much more margin. I mean, if I have a patient who comes and has read everything that can be read about prevention, is getting a colonoscopy every 3 years, is getting a skin exam every year, let's say for a woman, is getting a mammography every year, sees a gynecologist every year, and doesn't smoke, exercises, follows a good diet, and is taking some drugs because of a cholesterol problem, that patient, no matter what will be the issue that we have to deal with, will probably cost less to the system than somebody who is uninformed, very little knowledge in terms of how to keep in good health, has no access to preventive care, and comes to the hospital via the emergency room with a significant cancerous lesion in the abdomen. Okay, there is a fundamental disadvantage for hospitals that will have a payer mix where the majority of the patient will not be patients insured by private payers, and we forget that. And it's also important to remember that if an insurance system was adequate, it would provide more resources to care for individuals who are not the very well informed, the very well educated individuals, but instead would provide the resources to compensate for the imbalance that exists in the co-production of healthcare between the patient and the care providers, to make sure that actually we can provide the care with the.
Miami is a great example. There's proposed to shut down 2 Jackson Memorial hospitals with the bad economy, with layoffs, and also now with the new healthcare reform increasing Medicaid. All of that's going to be more non-private payers to your system.
Yeah, I understand.
Well, but Miami also, to be fair, before David jumps all over us, has very high reimbursement rates for Medicare. Everybody in the country would love to have our Medicare reimbursement rates. We make money. When we talk about private payers, we'll take more Medicare patients in South Florida. Everybody wants Medicare patients.
That's unusual.
Because it's very unusual, but it's because of the history of fee-for-service down here, the high number of specialists.
Mm-hmm.
But neurology is probably one of the high-cost areas of healthcare, and I assume that you guys have thought about whether it's better coordination of care, getting people in earlier,
Right.
because the most expensive thing you could do to a patient probably is to operate on their brain.
Well,
maybe.
I think that's right. I mean, I want to hearken to prevention, and
Yeah.
a lot of the Affordable Care Act does cover certain preventative services in a better way. Neurology, we don't think about prevention as much, but there are certain things that one can do, particularly for cardiovascular disease, that will be more covered under this new act. And we can hopefully improve both quality, reduce the high costs of chronic conditions, readmission rates that occur when people don't have good preventative health or follow-up after the condition. So I think that part of the Health Care Act, I think, could be helpful, and it may even end up reducing some costs.
And frankly, it's true that Medicare reimburses at a more reasonable rate. Medicaid does not, and we do see a very large fraction of Medicaid patients in the Jackson hospitals, and sure enough, there is no hospital that can survive on Medicaid rate. No, that's an absolute. And so there's a lot of subsidization that needs to happen within the hospital. But if you have a very small proportion of patients with a private payer, you're talking about a challenge for the hospital to maintain a good balance.
And of course, Medicare Advantage has been a huge profit center for most of the hospitals in this country, and they're going to feel, pulling back on that, because that's where the margins is. But the point is, because different payers pay different amounts, it forces everybody to turn themselves into a pretzel. This cost shifting from one thing to another, the need for a payer mix, has distorted the way in which we provide health care in this country.